Bismillahirrahmanirrahim. I'm Dr. Dalia Abd Ellatif, lectures at Chest Medicine Department, Mansoura University. I will speak about stepwise approach to a case of haemoptysis in ER or emergency room. I want you to know how to deal with a case of haemoptysis in emergency room. You should know how to diagnose and how to manage these cases. But before you deal with such cases, you should know some basic information as definition of haemoptysis, causes of haemoptysis, differential diagnosis of haemoptysis, and how to differentiate between true and false haemoptysis. Also the difference between haemoptysis and hematemesis. Then I will discuss how to diagnose and treat a case of haemoptysis. As regular definition of haemoptysis, haemoptysis is defined as coughing of blood originating from below the vocal cords. The most important word in the definition is below the vocal cord, because above the vocal cord is defined as false haemoptysis, which usually due to ENT causes, but true haemoptysis is coughing of the blood originating from below the vocal cords. Haemoptysis may be presented as blood-tinged sputum. In these cases, sputum contain spots of the blood, or blood-streaked sputum. In this case, sputum contain lines of blood, or maybe frank haemoptysis, I means bleeding without sputum. You can diagnose that haemoptysis is massive or life-threatening if the amount of the blood per one attack is more than 115 milli. Why this figure? Why 115 milli? Because it is the volume of the dead space. And if the dead space is occupied by blood, it will cause suffocation and it will be a life-threatening condition. Fortunately, only 5% of haemoptysis is massive, but mortality rate is 80%. Haemoptysis has multiple causes. Haemoptysis may be due to tracheobronchial diseases like acute bronchitis. Note that chronic bronchitis is not a cause of haemoptysis, but acute bronchitis is the most common cause of haemoptysis. Bronchiectasis, foreign body tumors like bronchial tracheal or laryngeal tumors, bronchial telangiectasia, cardiovascular causes as left ventricular failure, mitral stenosis, aortic aneurysm, pulmonary causes like tuberculosis, tumors, pneumonia, abscess, infarction, trauma, vasculitis and collagen disease, cystic fibrosis, alveolar hemorrhage, AV malformation. Other causes like blood diseases and anticoagulant therapy. From all these causes of haemoptysis, acute bronchitis is the most common and usually presented as blood-tinged sputum. When you deal with a case of haemoptysis, all these causes must be in your mind. Massive haemoptysis has a specific causes, and the differential diagnosis of massive haemoptysis, which is coughing of blood more than 150 milli per one attack. The causes may be pulmonary tuberculosis, pulmonary infarction, bronchiectasis, cystic fibrosis, lung abscess, necrotizing pneumonia, mitral stenosis, and pulmonary AV malformation. Source of haemoptysis may be bronchial circulation, pulmonary circulation, or anastomosis between pulmonary and bronchial circulation. Why haemoptysis occur? Haemoptysis occur due to vessels engorgement. Like in this picture, you see that the blood vessels are tortuous and engorged, erosion or rupture of the vessels, mucosal ulceration, or vascular granulation tissue. Okay, if you are at the emergency room and you have a case of haemoptysis, what's your clinical approach for management? First, you must make sure that it is true haemoptysis. Make sure it is not hematemesis or false haemoptysis, and I will discuss how to differentiate between them. Second, identify the severity of haemoptysis, because in massive or life-threatening haemoptysis, no time for diagnosis or knowing the cause of haemoptysis. It is emergency condition, so you must save the patient life, then diagnose your case. Third, from the patient history and the clinical examination, you will narrow the differential diagnosis. Fourth, from investigation, you will narrow the differential diagnosis more and more. Finally, appropriate treatment will be offered to your patient. To differentiate between true and false haemoptysis, true haemoptysis bleeding below the vocal cord, but in false hemoptysis bleeding above the vocal cords. In true hemoptysis, persistence as blood-tinged sputum, but false hemoptysis no blood-tinged sputum after the attack. In true hemoptysis may be mixed with sputum. False hemoptysis, no, not mixed with sputum. Patient with true hemoptysis usually has history of cardiopulmonary diseases, but false hemoptysis, this patient has ENT problem. True hemoptysis, chest X-ray may be normal and may be abnormal, but in false hemoptysis, chest X-ray is usually normal. To differentiate between hemoptysis and hematemesis, hemoptysis, coughing of blood, but hematemesis, vomiting of blood. Your patient, if have hemoptysis, usually has a history of cardiopulmonary disease, but hematemesis, this patient has history of GIT disease. Hemoptysis is bright red in color. Hematemesis, dark brown in color. Hemoptysis, the sputum remain blood stained, and the sputum after the attack is present for few days, but in hematemesis, usually followed by melena. In hemoptysis, usually mixed with sputum, but hematemesis mixed with gastric content. The blood in cases of hemoptysis is frothy due to presence of air, but in hematemesis airless. pH in hemoptysis is alkaline, but in hematemesis acidic due to gastric acidity. In hemoptysis, sputum contain hemosiderin-laden macrophage, which is not present in cases of hematemesis. After differentiation between true and false hemoptysis and differentiation between hemoptysis and hematemesis, you will ask your patient some point in his history to have a differential diagnosis. For example, if your patient use anticoagulant drugs, so the cause may be medication effect or coagulation disorders. If the hemoptysis is associated with menses, so the cause may be catamenial hemoptysis. If your patient has a history of dyspnea on exertion, fatigue, orthopnea, paroxysmal nocturnal dyspnea, frothy pink sputum, so the cause will be congestive heart failure, left ventricular dysfunction, or mitral stenosis. If your patient has a history of fever and productive cough, so upper or lower respiratory tract infection, acute bronchitis, lung abscess may be suspected. If your patient has a history of breast, colon, or renal cancers, so endobronchial metastatic lung disease may be suspected. Patient with a history of chronic lung diseases, recurrent lower respiratory tract infection, cough, copious purulent sputum, or pustural sputum related to puncture, so differential diagnosis may be bronchiectasis or lung abscess. And according to the history, I will have an investigation to confirm this differential diagnosis. Okay, if your patient has melena, alcoholism, chronic use of non-steroidal anti-inflammatory drugs, so it is not hemoptysis, it is a hematemesis, and the cause may be gastritis, gastric or peptic ulcer, or even esophageal varices. Patient with pleuritic chest pain, tender cuff muscle, so pulmonary embolism or infarction may be the cause. And lastly, if your patient have toxemic manifestation, don't forget tuberculosis as a cause of hemoptysis. After taking a history from your patient, you will do examination. Okay, during the examination, if your patient is cachectic, clapping, hoarseness of voice, Cushing syndrome, hyperpigmentation, Horner's syndromes, all these signs during the examination are called paramalignant syndrome. So you will suggest bronchogenic carcinoma or squamous cell lung cancer, small cell lung cancer. If your patient have clubbing, so the differential diagnosis of clubbing and hemoptysis will be lung cancer, bronchiectasis, and lung abscess. During examination, if you found your patient to have dullness to percussion, fever, crepitation, and from his history he has fever, expectoration, so the diagnosis may be pneumonia. If your patient has gingival thickening, saddle nose, nasal septum perforation, Wagner granulomatosis may be the cause. During the examination, if you found mid-diastolic rumbling murmur, so you will think about mitral stenosis. Lymph node enlargement during the examination with cachexia and skin lesion, Kaposi sarcoma secondary to HIV may be suspected. If your patient has tachypnea, tachycardia, dyspnea, S1, T3, Q3, pleural friction rub, unilateral leg pain and edema, and especially if he has history of chest pain and tender cuff muscle, so pulmonary embolism may be suspected. Lastly, if your patient has tachypnea, tachycardia, hypoxia with congested neck vein, galloping heart, fine basal crepitation, so cardiac causes of hemoptysis will be suspected, like chronic heart failure or congestive heart failure caused by left ventricular dysfunction or mitral stenosis. After history taking and examination, I will ask the patient to do some laboratory investigation to help me in the diagnosis of hemoptysis. These laboratory investigations include: number 1, white blood cells with differential white blood cells count. Increase white blood cells count and shift to the left is give me diagnosis of upper respiratory tract infection or lower respiratory tract infection. Hemoglobin and hematocrit usually decreased in cases of anemia. Platelet count is decreased in thrombocytopenia. Bleeding profile like PT, INR, PTT will be increased in patients with anticoagulant use or disorders of coagulation. So please, if a patient come to you in emergency room with hospital, one of the most important questions to ask him about is history of anticoagulant use or history of disorders in coagulation. Okay, ABG will reveal hypoxia and or hypercapnia. D-dimer is positive in cases of pulmonary embolism, but don't forget it may be positive in other diseases. D-dimer is a good negative test for pulmonary embolism. If D-dimer is negative, this excludes pulmonary embolism, but positive D-dimer didn't confirm the presence of pulmonary embolism except if you suspect it by history taking examination and other investigation like CT angiography. Also, we can do sputum, gram stain, culture, acid fast smear, and cultures for patient. We can do sputum cytology. We can do some specific tests for tuberculosis if suspected, like tuberculin test, Zell-Nelson staining, Löwenstein-Johnson media. ESR, we know that it is increased in multiple diseases, but ESR more than 100 is specific for: number 1, TB, number 2, malignancy, number 3, collagen disease like systemic lupus erythematosus. After laboratory investigation, I will ask my patient to do radiologic investigation. One of the most important is chest X-ray. Chest X-ray in cases of hemoptysis may be normal and may be abnormal. What is the most common abnormality? I may found cardiomegaly, increased pulmonary vascular distribution, and this indicate cardiac disease like chronic heart failure, mitral valve stenosis. You may found in chest X-ray cavitary lesion, which indicate lung abscess, TB, necrotizing carcinoma. Okay, diffuse alveolar infiltrate may be found in chest X-ray. Diffuse alveolar infiltrate may be found in chest X-ray, and the cause may be chronic heart failure, pulmonary edema, or aspiration. Hilar adenopathy or mass may be present in cases of carcinoma, metastatic diseases, or infection. Lobar or segmental infiltrate suggestive for pneumonia, thromboembolism, obstructive carcinoma. If you found the mass lesion, nodule, or granuloma, the differential diagnosis may be carcinoma, metastatic disease, Wagner, septic embolism, and the diagnosis will be confirmed by another methods of diagnosis like a biopsy in cases of cancer, for example. Patchy alveolar infiltrate may suggest bleeding disorders, idiopathic pulmonary hemosiderosis, or Goodbusher syndrome. This chest X-ray of a patient to come to emergency room with hemoptysis. When you do the chest X-ray, this abnormality could be detected. What is the abnormality? We can detect that cavitary lesion present in the right middle lung zone. Oh, what is the differential diagnosis of this cavitary lesion? It may be TB, tuberculosis, may be pyogenic abscess, may be cancer, may be cavitary lesion, malignant cancer, malignant cavitary lesion. So other investigation will be to confirm the diagnosis. Okay, another chest x-ray of a patient with hemoptysis, or we can find that I have homogeneous opacity rounded present also in the left middle lung zone. It may be a mass, so diagnosis of this mass will be further need another investigation like CT chest, CT guided biopsy, fiber optic bronchoscopy, and so on. What about this chest x-ray? Yes, it is normal chest x-ray, but the patient come to the emergency room with hemoptysis. Is this x-ray mean that this hemoptysis is not due to cardiac or pulmonary causes? No. Normal x-ray not exclude presence of pulmonary causes. So this patient must do further investigation. For this patient, I will do CT chest, computed tomography. Tomography is valuable in selecting cases for better show the presence of lung cavities, solid masses, and mediastinal or hilar lymph node. It is complementary use with fiber optic given as a positive yield of pathology, and it is useful for excluding malignancy in high risk patient. Also, allow application of a specific imaging technique. We have multiple types of CT. It may be high resolution CT. High resolution CT means the thickness of the section may from 1 to 3 millimeter, and it is useful in cases of bronchiectasis. Also, spiral CT with pulmonary angiography or CT chest with contrast with thin cuts on pulmonary artery is useful in cases of pulmonary embolism. So you must specify or know the type of the CT chest you will prescribe for your patient. If you suspect of bronchiectasis, please ask him to do high resolution CT. If you suspect pulmonary embolism, please ask him to do spiral CT chest with pulmonary angiography. This picture shows CT of chest of a patient with hemoptysis. The yellow arrow refers to the tumor mass present in the right main bronchus, obstructing the right main bronchus. Also, this CT chest with contrast, demonstrate filling defect present in the pulmonary arteries, which is specific for pulmonary embolism. Chest x-ray of a patient with a bronchiectasis, but the CT is highly specific. High resolution CT can demonstrate the bronchiectatic changes. We can see the singlet ring appearance and tramline appearance. Okay, after doing radiological investigation, we can do what's called fiber optic bronchoscopy. Fiber optic bronchoscopy has two values, either diagnostic or therapeutic. It can diagnose, it may be used as a diagnostic tool for centrally endobronchial lesions and allow direct visualization of the bleeding vessels. Also, fiber optic bronchoscopy permit tissue biopsy, bronchial lavage, or brushing for pathological diagnosis. Fiber optic bronchoscopy also can be provide direct therapy like installation of diluted adrenaline, iced cold saline, wedging and tamponade, or use of Fogarty catheter balloon. These pictures shows the Fogarty catheter balloon that can be used through the fiber optic bronchoscopy, and it will be inflated to isolate the bleeding loop from other lung. Here we can see that I have an opacity in the chest x-ray. It may be due to collapse. By fiber optic bronchoscopy picture, we can see a mass that obstruct the bronchus. Another investigation is rigid bronchoscopy. Rigid bronchoscopy has advantage and disadvantage. Its advantage is wide suction channel, so I can do suction of the blood, so the patient will be recurred. Ensure ventilation, allow interventional procedures application in cases of massive hemoptysis like laser, electrocautery, cryotherapy. But its disadvantage is that it requires general anesthesia and needs special skills. Angiography. Advantage of angiography is one of the radiological methods used during assessment of a case of hemoptysis. It is a gold standard diagnostic tool for suspected pulmonary embolism. can diagnose AV malformation, allow management of some cases of hemoptysis using endovascular embolization. But its disadvantage is embolization of the spinal arteries that may lead to paraplegia and need special skills. Ventilation perfusion lung scan, one of the most important investigation to diagnose a case of hemoptysis, especially if you suspect also pulmonary embolism. Now we will discuss algorithm for diagnosing non-massive hemoptysis. Now I have a case of non-massive hemoptysis. It is not massive. So in non-massive hemoptysis, less than 150 milli per attack. So first, take history and physical examination for your patient. If you suggest that it is not hemoptysis, it is hematemesis or false hemoptysis, please refer to the specialist. But if you suggest that hemoptysis is a bleeding from below the vocal cords, it is true hemoptysis, do chest x-ray. Chest x-ray may have one of the three possibilities. It may be normal, have a mass, or other parenchymal diseases. If the chest x-ray is normal and your patient has no risk factor for cancer, the history not suggestive of lower respiratory tract infection, please observe your patient. Okay, or you may consider bronchoscopy or high resolution CT. If your chest x-ray is normal and no risk factor of cancer, and the history suggestive of lower respiratory tract infection, please observe your patient and give him oral antibiotic. If the bleeding stop, okay, no further evaluation. If the bleeding is recurrent or still present, so please we will do another investigation like bronchoscopy. If you have normal chest x-ray and you have a risk factor for cancer, please, even normal chest x-ray, do CT chest and fiber optic bronchoscopy later on. If the chest x-ray have a mass, consider CT chest for staging, then fiber optic bronchoscopy. If other parenchymal diseases present in the chest x-ray, high resolution CT may be done for this patient. If the high resolution CT no specific diagnosis suggestive, please do fiber optic bronchoscopy. But if the diagnosis suggested, laboratory evaluation focused towards suspected diagnosis. This algorithm for non-massive pulmonary embolism. For management of, for non-massive hemoptysis, not pulmonary embolism, I'm sorry. Okay, for management of hemoptysis, how to manage a case of hemoptysis? The goal of management is to evaluate the severity of hemoptysis, if it is severe or not, massive hemoptysis or not. Number 2, airway protection and patency, identify the site of bleeding, protect the contralateral uninvolved lung by using Fogarty catheter, for example, stop the bleeding, and lastly, treat the cause of bleeding. If you have non-massive hemoptysis, please, treatment of the underlying cause will control this hemoptysis. But if the hemoptysis is massive, you will use medical, surgical, endobronchial, or even endovascular treatment. For medical treatment, endotracheal tube, single wide bore or double lumen, position of the patient in sitting position or the bleeding side must be down, large bore intravenous line, and blood transfusion should be given cautiously because your patient may have congestive heart failure or other problems. Okay, supplemental oxygen and mechanical ventilation. Avoid cough suppressant, if necessary give benzodiazepine, and lastly batracin may be used as a vasopressin. Surgical treatment include emergency resection for bronchogenic mass, resection for bronchogenic mass after patient stabilization, or surgical resection for aspergilloma if it is the cause of hemoptysis. Endobronchial therapy. Endobronchial therapy by use of a Fogarty catheter, for example. These pictures have a different type and size of the Fogarty catheter to identify source or rate and to slow or arrest the bleeding. Endovascular line of treatment. In most patients, the bleeding originates from bronchial arteries rather than pulmonary arteries. Transcatheter embolization is effective in immediate control of massive hemoptysis. Recurrence may occur? Yes, may occur. What is the cause of recurrence? It may be incomplete embolization of artery, recanalization of a previously embolized artery, revascularization through collateral circulation, or progression of basic lung disease. These pictures demonstrate before and after embolization of the artery. Pictures on the left side, here you can see tortuous and hypertrophied vessels after embolization or decrease the vascularity and the hypertrophy. Also here transcaster embolization. A pictures highly tortuous blood vessels, B pictures near normal blood vessels, so the bleeding will decrease and the hemoptysis will be controlled. Okay, management of massive hemoptysis. Massive hemoptysis, you don't search for the cause. Please first try to save the patient's life, then search for the cause of hemoptysis. Number 1, ICU admission, then conservative medical care, rigid bronchoscopy, or if hemoptysis stop, investigate for the cause. But if the hemoptysis didn't stop, please surgical therapy or embolization of the artery may be needed. Thank you.